It's really a pleasure to introduce and request the next speaker. She is very well known to me. She's a colleague, Nonthalee Pausawasdi. She is president of your Thai GI endoscopy, program director of WGO Endoscopy Tertiary Center, and she works at Sri Raj Hospital. Apart from that, I'm really indebted to her because she's trained quite a few gastroenterologists from Pakistan. And she's a master, so she's going to speak on Masterclass on how to manage GI bleeding. Over to you, Nonthalee.
Thank you. I want to say hello and good afternoon, everyone, and thanks for sticking around this long. And I want to thank the organizing committee, Professor Ratagan, for giving me this opportunity to be part of this program once again this year. And my task this year is going to talk about Masterclass in Management of Upper GI Bleeding. My outlines today of the talk is that I'm going to introduce to you the principle of treating upper GI bleeding. I'm going to be focusing on non-variceal bleeding. I'll show you the level of evidence to support the current practice because we're talking about evidence-based practice this session. I will also show you the emerging evidence of the novel endoscopic techniques. Finally, I will finish with the tips of managing upper GI bleeding. Starting off with introducing to you several guidelines of management of upper GI bleeding have been published for the past 10 years, starting with the Asia Pacific, the International Consensus Guidelines. But just for the past couple of years, the American guidelines and the European guidelines have been published about non-variceal upper GI bleeding management. Also, the Bavino group, as well as the European group, have also published variceal guidelines. But for the purpose of my talk today, I'm going to be focusing on the non-variceal bleeding. And if you break down the guidelines, all the guidelines, you will see that the principle of upper GI bleeding can be divided into three aspects. Number one is pre-endoscopic therapy. Number two is endoscopic therapy. And finally, post-endoscopic management. Pre-endoscopy is going to involve the hemodynamic resuscitation, blood transfusions. We need to have strategy to transfuse blood. Then we re-stratify the patients. There's several scoring systems that we can use. Also, pre-endoscopic medical therapy. And I'm going to show you what the evidence that we have to support the current recommendations. Then moving on to the endoscopic management, we talk about timing. We talk about endoscopic techniques to take care of high-risk bleeding ulcer. We talk about adjunct therapy. And, you know, believe it or not, when I was doing my fellowship training, and many of us here would also agree with me, back in those days when we practiced our endoscopy management, we didn't really have any evidence to tell us whether or not we did the right thing. But now, once I finish my talk, I hope that you'll see how far we have come in terms of evidence-based practice. Finally, post-endoscopic management, we talk about high-dose IV PPI for high-risk patients. We also talk about treating H. pylori and managing antiplatelets. And I'm going to show you, the evidence to support all these practice recommendations. Starting with pre-endoscopic management, I have come across several studies, and I'm surprised that the level of evidence that we're following is actually 1A or 1B when it comes to pre-endoscopic management. Resuscitation, blood transfusion, everyone must know by now. The New England Journal of Medicine paper, which was published 10 years ago now, the use of risk stratification, different scoring system like Rocco score, GBS, which is Glasgow-Blatchford score, as well as AIM-65, and also the use of high-dose IV PPI for pre-endoscopic therapy. I'm going to touch on real quickly about the strategy for blood transfusion. Restrictive versus liberal strategy. As you might have heard that 10 years ago, this very important, a landmark study, randomized control trial that divided the patient into two groups. The first group is being transfused using restrictive strategy, meaning the target range of hemoglobin is about 7. And then the threshold of the liberal strategy group is about 9. So basically, if you keep the hemoglobin right around 7, these patients, we found that they had a better 6-week survival compared to the liberal strategy. And from that point on, we have been practicing a restrictive strategy. Having said that, I think it is important to emphasize that patients in this study, they all have been treated endoscopically within 24 hours of presentation, number one. Number two, they excluded patients who had hemodynamic instability and did not respond to resuscitation. Number three is that they also excluded patients with active acute coronary syndrome. But for stable coronary syndrome, that's okay to be included. So if you want to apply this to your practice, you make sure that your patient population is similar to these patients in the study. Moving on to risk stratification. We do have a meta-analysis comparing the performance of 3 most popular scoring system, including Glasgow-Blatchford score, Rocco score, and AIM-65. As you can see on this table here, a GBS score has a pool sensitivity of 99% with specificity of 0.2. Obviously, if the test is very sensitive, the specificity is going to drop. Rocco score, what about pre-endoscopic Rocco score? It does very well with a 96 to 98% sensitivity. And if you compare that with the AIM-65, you can see that these two tests perform much better than AIM-65 when it comes down to prediction of patient risk stratification, meaning mortality as well as the need for therapeutic intervention. And therefore, AIM-65 hasn't really been recommended to use in several settings. However, it does predict the in-hospital 30-day mortality very well. So again, for Asian populations, GBS score seems to perform the best. Now, moving on to the level of evidence for endoscopy. First thing we want to talk about is the timing of endoscopy. All the recommendations say that we should do endoscopy within 24 hours. We'll see some data to back that up. So the timing of endoscopy, this is another landmark study published a couple of years ago in New England Journal of Medicine. This is a randomized controlled trial, a patient of over 500 who presented with upper GI bleeding with a high GBS score of 12. The patients were divided into two groups. The first group is to have emergent or urgent endoscopy within 6 hours. The other group is to have endoscopy after 6 hours, but within 24 hours. They compared these two groups, and what they found was that 30-day mortality was much better in the group who had early endoscopy, meaning if you do procedure within 6 to 24 hours, the patient seems to do better than you go rush in to do endoscopy when the patient may not be well resuscitated. So do it early, but not too early. Make sure your patient's well resuscitated. A few years later, which is actually this year, the same group, which is the Hong Kong group, James Lau and Joseph Song, did a huge population-based study across Hong Kong just to prove about the importance of timing of endoscopy. They divided the patients into 3 groups. First group is to have urgent endoscopy, meaning the procedure is being done within 6 hours. The second group is within 6 to 24 hours. And the last group is after 24 hours, but within 48 hours. And what they found is that, I hope you can see this. If you look at this graph here, this graph is assessing mortality as well as rebleeding. The black line here is a patient who had urgent endoscopy, which is less than 6 hours, and this dot here is the group with early endoscopy, which means within 6 to 24 hours. And as you can see, the mortality rate is the best among those who had procedure done between 6 to 24 hours, emphasizing the importance of proper timing of performing endoscopy. Again, once you go in, you want to be able to recognize the stigmata of peptic ulcer. And here is cartoon, not a cartoon, it's images of Forest classification of peptic ulcer disease. The first three here, which is Forest class 1, 2A, and 2B, adherent clot, non-bleeding visible vessel, and spurting, these are considered high-risk stigmata, whereas Forest class 2C and 3, which is clean-based ulcer and hematine spot, these are low-risk endoscopic stigmata with a lower risk of rebleeding. So once you recognize these bleeding stigmata, then you want to understand the concept of using endoscopic therapy to treat all these lesions. Well, the standard techniques that we use is a combination therapy, meaning we use epi injection or adrenaline injection in combination with thermal therapy. However, within the past 10 years or maybe 15 years, mechanical therapy like through the scope clips has almost taken over the younger generation of endoscopists. They would prefer using clip over dual combination therapy. But either way it works. So I'm gonna show you, here's a video demonstrating the video demonstrating the technique of dual therapy. So here you see adherent clot. This is a peptic, a patient with peptic ulcer bleeding, and you can see adherent clot right here. And what we're doing here is to inject underneath the clot with 1 to 10,000 epinephrine. We do a full quadrant injection. The reason for doing that is that most of the time you have feeding vessels underneath that adherent clot. So you want to apply some epinephrine or adrenaline to create vasoconstriction. And then you remove that clot with a grasp of forceps or snare. And then you basically cauterize the non-bleeding vessel underneath that clot. So this is combination therapy. And here's a standard treatment. So what about the new and novel endoscopic techniques? The technique that people use a lot is the hemospray. And then besides from hemospray, we do have over-the-scope clip. And then besides from these two techniques, lots of experts proposed using monopolar hemostatic forceps with soft coagulation. Besides from these three, we do have other techniques like Doppler endoscopic probe or EUS guided vascular therapy, as well as endoscopic suturing device. But for the purpose of my talk today, I'm going to focus mostly on these two. I'll touch on a little bit about the monopolar, and then we will conclude which technique is best for which condition. Starting off with hemostatic powder, I'm going to show you a video of a hemostatic powder. So this is not peptic ulcer bleeding per se. This is a post ERCP with sphincterotomy bleeding, but I just want to show you how the device is being used. So the device actually consists of this powder catheter here, and also a canister with a controller. You can pump 1 to 2 pump. The powder is going to be delivered through this catheter. Here you can see once you deliver the powder, it's going to spray onto the bleeding area. And the idea of this powder is that it creates an absorptive barrier to speed up the coagulation time. Therefore, the bleeding stops and platelet aggregation occurs quicker. So we want to look at the evidence to support the use of hemospray. You see here last year, Again, James Lau, the Hong Kong group, reported a study. It's a non-inferiority randomized control trial comparing hemostatic powder and standard treatment in patients presenting with active bleeding from non-varicose lesions. As you can see here, this plot here demonstrates that the hemospray is not inferior to standard technique in terms of rebleeding at 30 days, as you can see here. Now we have the data that hemospray is not inferior. What about the following study? The same group, Joseph Sung and James Lau, they did a prospective trial, multi-center, patient of over 70 cases, and they only selected patients with peptic ulcer bleeding with high risk stigmata, being forest class 1A and 1B. If you guys remember, 1A is the spurting and 1B is also oozing. And the primary outcome of this study is to assess the efficacy of hemospray or hemostatic powder and rebleeding at 72 hours and delay rebleeding. The results demonstrated that the efficacy of hemospray is about 90.9%, which is quite high considering high risk bleeding ulcer. But, the rebleeding rate in 3 days is about 13%, which is also not low. So, with that, this is kind of giving us an idea that if you really need to, you may be able to use a hemospray to treat high risk peptic ulcer bleeding. And here, this table is just to demonstrate that patients with forest class 1A has a higher incidence of early rebleeding compared to 1B. Also, they appear to have higher mortality compared to 1B. So remember, when hemospray came out the very first time, people criticized that hemospray is good for rescue therapy because the residency time of the spray is only going to be for 24 hours. So we used to use that for rescue therapy. But once we had more studies demonstrating the ability of hemospray to be used as primary method, it seems to do reasonably good to be used as primary method. But then the study was also criticized that, maybe because some of the patients, 20% of the patients had tumor bleeding. So this study tried to prove that even if you just pick out patients with peptic ulcer bleeding, high risk, hemospray is still going to work for you for about 90%. So now we have a meta-analysis demonstrating that hemospray actually, compared to standard therapy, it's effective for hemostasis and also rebleeding, but also some of them fail. So, with this in mind, you kind of have to look and see what kind of patient population you have, what situation you have, what kind of backup plan you have. Hemospray can be one of the tools that you can use as primary method. Besides from peptic ulcer bleeding, this is a study from Thailand. Dr. Rapad is the lead investigator in this. This study assessed the utility of hemospray in treating bleeding tumor, multi-center study, and this study demonstrated that if you have a patient with bleeding tumor, you can treat it with hemospray. The efficacy is quite good. The rebleeding rate when you use hemospray compared to standard endoscopic therapy, meaning injection with adrenaline or clip or cautery, it seems that hemospray gives better results in terms of 30 days rebleeding. It also provides you better immediate hemostasis. And in terms of 6-month survival, they're very similar, but the study didn't decide to assess the survival at 6 months anyway. So here again, another information to show that maybe hemospray is actually something that you want to have in your toolbox. Moving on from hemospray to over-the-scope clip. So this is our patient with refractory bleeding. We treated her until we created this hole, which is a perforation from coaptation. we decided to use a over-the-scope clip, which could treat both ulcer and perforation, and the patient did well. The story about the over-the-scope clip is that when it first came out, the study assessed the utility of over-the-scope clip for recurrent peptic ulcer bleeding, difficult ulcers. It's been proven that over-the-scope clip is more superior compared to standard method for difficult recurrent bleeding ulcer. That's been proven 2 years ago. Now, people started to adapt over-the-scope clip to treat as an initial treatment. So instead of recurrent bleeding, difficult ulcer, you use it firsthand compared with standard therapy. And it appears that over-the-scope clip did better, meaning less rebleeding at 30 days. So now over-the-scope clip is in the market for a primary method. What else do they do? This is another study comparing. It's a big randomized control trial comparing the performance of over-the-scope clip and standard treatment. And again, over-the-scope clip does better than standard treatment in terms of clinical success for difficult ulcer, and also it does better with rebleeding. So with that, with experience, experts recommend using over-the-scope clip as the primary therapy because it appears to be superior to the standard therapy. But wait a minute. Just this year, this study came out from Hong Kong group, again, James Lau and Joseph Sung, and my good friend Shannon Chan is the first author in this. So what they did was that they compare over-the-scope clip and standard therapy in ulcers that is larger than 1.5 centimeters, which is considered difficult ulcers. So this is a randomized multi-center international study. And what they found is that when they use over-the-scope clip as a primary hemostasis for high-risk bleeding peptic ulcer, meaning more than 1.5 centimeters, it didn't show any differences in terms of decreased 30-day rebleeding. So this started to raise some eyebrows as to, then should we really use this for primary method? Well, you're going to have to stay tuned for more data to come. But as of now, most of the guidelines as well as experts agree that over-the-scope clip can be used as a primary tool for difficult ulcers. Leading up to this, the evolution of guidelines for endoscopic therapy, as you can see, 5 years ago, the Asian Pacific group, they didn't mention anything about over-the-scope clip. Hemospray was just a temporary control of bleeding. You recommended to be used as rescue therapy. But right now, the American guideline and the European guideline, basically they suggest we can use hemospray for actively bleeding ulcer. We can also use over-the-scope clip as first line in actively bleeding ulcer. Also, the monopolar with soft coag, which I have not mentioned in this talk, has been mentioned in the guidelines as well. So, from this point on, I think for those of you who are not familiar with these techniques, you might want to get your hands on it, at least the hemospray, because it's very easy to do. The over-the-scope clip can be difficult and it needs a little bit of training. Last but not least, we're moving on to post-endoscopy, and we learned for a long time based on several RCTs that high-dose IV PPI is needed for 72 hours for high-risk patients. As you can see, before I go to the last part of my talk, you see that the level of evidence for our current practice is actually level 1A or B, because we've got all the RCTs, we've got meta-analysis for, pretty much everything that we do. Now, let's talk about post-endoscopic therapy being a high-dose IV PPI. Several studies have demonstrated that IV PPI is actually effective for decreasing or minimizing rebleeding. That's high-quality evidence. But the drawback of that is that you're going to need to admit the patient for 72 hours at least, right? Because you give them IV PPI. So ever since PCAP came along, PCAP is, I think you've had session of PCAP yesterday. So PCAP is one of the newer acid blocker. The commercial name in Thailand is vonoprazan. So it came along as an oral form of acid suppression. So our group had performed a study, is a randomized control trial non-inferiority study comparing vonoprazan and IV PPI for prevention of rebleeding after successful endoscopic therapy for high-risk bleeding ulcers. Now, this is a multi-center study throughout Thailand, different regions, randomized control trial, and we only recruited patients with high-risk bleeding ulcer of over 190 patients. We randomized them into vonoprazan group and PPI group. 98 and 96 patients for each group. And the study results show that the primary outcome is to look at the 30-day rebleeding rate. Remember, this is a non-inferiority study. So the vonoprazan actually was deemed not to be inferior to PPI. If you look at this number, you might be thinking that maybe vonoprazan is superior to PPI, but the study was not designed to be a superiority study, so we can only conclude that it's not inferior. And if you look at the 3-day rebleeding rate, 7-day rebleeding mortality, then you can see that the vonoprazan is really not inferior to PPI. I can't believe last year when I gave a talk about the peptic ulcer bleeding, and I briefly mentioned vonoprazan, Professor Ratagon here asked me, do I think vonoprazan has a future in peptic ulcer bleeding? Because at that time, there was some data about GERD, about erosive esophagitis, but never really anyone studied vonoprazan in peptic ulcer bleeding. But this year here, I've got an answer for you. It seems that it may be an alternative. So finally, I'd like to conclude that, the tips of managing upper GI bleeding, besides from risk stratification, resuscitation, I think in 2023, we have strong evidence supporting that conventional therapy still work, is still effective, but there are some difficult ulcers that you're gonna need alternative method to treat those, such as big ulcer, posterior wall ulcer, or massive bleeding ulcers, and hemospray over the scope clip would be your good friends. You should have them in your toolbox. Finally, I'd like to thank you very much for your attention. I'll be happy to answer any questions. Thank you.
I think we'll take the questions at the end of the both talks. So thank you. Thank you.
So now it gives me a tremendous pleasure to introduce our next speaker, Dr. Afif from Canada. Dr. Afif is currently an associate professor of medicine in the Division of Gastroenterology and the Division of Clinical Epidemiology. He's the current Montreal General Hospital GI Site Director and the IBD Research Director. He has a particular research interest in improving treatment outcomes in inflammatory bowel disease. He's from McGill University Health Center, Montreal. And it's such a pleasure to have you here. And I love to hear what you have to tell us today, please.
Thank you very much for the introduction, and thanks for staying for the last lecture of the day. It's always hard to stay till the end. So I'll be talking a little bit about therapeutic drug monitoring and IBD. We'll just get started. These are my disclosures. So when I was first asked to give this talk, I was only going to talk about biologic medications, but after the last day or so and speaking to the gastroenterologists here, I realized that there's still a lot of thiopurine use in Thailand, and so I decided to add some slides looking at therapeutic drug monitoring with thiopurines as well, because I think it's important, and there's some good evidence to suggest that it might actually be helpful in managing patients with inflammatory bowel disease. So just to start off with, so most of you have probably seen this sort of diagram of azathioprine being sort of cleaved to 6-mercaptopurine, and then the active metabolite of the thiopurine is 6-TG or 6-thioguanine. There is some evidence to measure TPMT, thiopurine methyltransferase, in patients before starting azathioprine to sort of identify those patients that are either homozygous or heterozygous to TPMT. And so there's about maybe 11% of patients that are either heterozygous or homozygous to TPMT. So if you're actually homozygous, the recommendation is to avoid using azathioprine or 6-MP. If you're heterozygous, you use a half dose, and if you're normal, then you can use a full dose. You still need to continue monitoring the CPC and liver enzymes, but certainly it gives you a good idea of avoiding leukopenia and neutropenia in those patients that are either homozygous or heterozygous when you give full dose thiopurine. And so in terms of therapeutic drug monitoring, there's two metabolites that we can measure. And so those are 6-TG, 6-thioguanine, and 6-MMP or 6-methylmercaptopurine. And so the effective dose of 6-TG is around 230 to 450. If it's higher doses, that leads to myelotoxicity. And if you have high doses of 6-MMP, that leads to hepatotoxicity. And so what's the evidence? So this is sort of older evidence, and there hasn't been much studies since the early 2000s looking at this, but there is evidence to suggest that once you start hitting a 6-TG of about 230, that actually increases your risk of having clinical response in patients. Interestingly, it's really the measurement of the 6-TG that's most important, and not necessarily the dosing of the medication. And so you can see on the bar graph on the right, regardless of what dosing you had, there was no difference in clinical response. It was really just measuring the 6-TG level, and everyone metabolizes thiopurines in a different way. And so measuring the 6-TG level is the most accurate way of assessing what the levels are and the efficacy of the medication. In terms of guidelines, in terms of reactive testing with thiopurine, so this is the AJA guidelines that were published about 10 or 12 years ago. And so there is not great data, but there is some data to suggest that thiopurine metabolite monitoring be used to guide treatment changes and look for patients that are not responding to therapy to see if there's room to optimize. And this was based on a few studies that have looked at using this sort of algorithm to kind of assess patients. And so what do you do with these levels? So if you're able to get them, so if you're in the therapeutic range and your 6-MMP is normal, then great. And if you're doing clinical remission, great. But if you're not doing well and you're not in remission, that means that you're thiopurine refractory, you're appropriately dosed, and it's time to move over to a different medication. If your 6-TG level is low and your 6-MMP level is low, either you're underdosed or non-compliant. I've had a couple of patients that have told me that they've been taking their thiopurine regularly, and then when I measure their 6-TG, it's very low, and then when I confront them about it, they say, oh yeah, I only take it every second or third day. So it's a good way to check for compliance for patients on thiopurines. And if it's high, the 6-TG, and you're still not doing well and you're not in clinical remission, then you're thiopurine refractory. It's time to change therapy. And then there's this sort of other group of patients, which are shunters, which have a low 6-TG level and a very high 6-MMP level. And so if your ratio of 6-MMP to 6-TG is greater than 11, you're a 6-MMP shunter. And I'll show you what that means in a second. And so what that means is that in patients that are have a baseline sort of low 6-MMP to 6-TG ratio, when you start increasing it, increasing the dose of the thiopurine, it sort of goes up to about 9 or so is the ratio. But in patients that are not, and that happens in responders and non-responders, and patients that are sort of more heavy shunters, when their baseline 6-MMP 6-TG ratio is greater than 11 and starts at 18, then trying to increase the azathioprine dose doesn't really help, and you get actually more shunting, and your 6-TG levels don't increase, and your 6-MMP levels become high, and it puts you at a higher risk of toxicity. So there is a couple of studies taking a look at this, and this is one sort of small study looking at it and showing that those patients that were refractory to treatment, if you were able to assess those patients and start them on allopurinol. So I didn't sort of mention it before, but I'll just go back and just show you that graph. So allopurinol, you can see here is the xanthine oxidase inhibitor at the bottom. And so if you inhibit xanthine oxidase, you sort of shunt the pathway a little bit more towards 6-TG. And so if you actually use allopurinol at 50 milligrams or 100 milligrams and lower your dose of your thiopurine to about 25%, there's a much higher chance that you can actually get more favorable 6-TG and 6-MMP ratios. So I've sort of had this multiple times in clinical practice, and it certainly works in those patients that are known shunters that have a higher ratio of greater than 11, that if you add allopurinol and decrease the azathioprine dose, that you actually do a bit better. And so just sort of in closing in terms of the therapeutic drug monitoring for thiopurines, so it's more of a reactive type of scenario. And so if your patients aren't doing well, they're not in clinical remission, and you want to see if there's any room to increase the dose or to add allopurinol if they're a shunter, then certainly you could consider doing 6-TG and 6-MMP testing. There's no data to suggest that you should do this proactively. So if your patient's doing well and things are great, then there's no advantage of doing testing in patients on thiopurines. So just a couple of small little things with thiopurines as well. So in those patients that are on combo therapy, we know that combo therapy with anti-TNF, particularly infliximab, is superior to monotherapy. And so there have been studies taking a look at whether you can actually decrease the dose of the thiopurine, and maybe you don't need to be on full dose thiopurine. And in this study, they actually halved the dose of the azathioprine, and they were still able to have a favorable pharmacokinetic profile, so with good trough levels and avoidance of antibodies. So that's another possibility, is that in those patients that are on combo therapy with a thiopurine and with an anti-TNF, you could actually maybe decrease the dose of the 6 of the thiopurine. And if you're able to maintain sort of a 6-TG level of about 130 or so, those patients end up doing well pharmacokinetically as well. As opposed to if you stop, those patients end up having a higher risk of antibody formation. So something to think about in clinical practice for those patients that are on combo therapy. And lastly, in terms of combo therapy, you've all seen the SONIC study many, many years ago. But I just wanted to highlight one thing, which was that in this post hoc analysis of the SONIC study, what you can see here is on the top graph, in those patients that were on combo therapy, they had a much higher chance of having higher levels of infliximab. So their quartile analysis, those patients on combo therapy actually had much higher levels of infliximab. But when you broke it down in terms of whether these patients were on infliximab alone or on infliximab azathioprine, and the efficacy of the medication, whether they're on mono or combo therapy, what was more important was that you were in the 4th quartile. So whether you're in the 4th quartile because you're on combo therapy, or you were just on monotherapy and happened to make it to the 4th quartile as well, your patients did equally as well. And so there is this thought that maybe you don't need combo therapy for everybody, and maybe if you just dose escalate patients on anti-TNF alone, that you can avoid using thiopurines in the first place. So that's my sort of small sort of interlude on TDM for thiopurines. And then, so I just want to spend the rest of the talk talking about TDM for the biologic medications. And again, our sort of quality of evidence compared to the GI bleeding literature is very, very low quality. And so just sort of, there are ongoing studies, but we don't have great evidence for a lot of these things, but I'll show you the evidence we do have. So these are the AGA guidelines, and basically recommending that there's a conditional recommendation of using therapeutic drug monitoring in a reactive setting. And so, i.e. in patients that are not doing great or have a high fecal calprotectin or active disease, whereas there isn't any specific recommendation because there's a knowledge gap in terms of using TDM proactively. And so we know that levels of infliximab and adalimumab, so the TNFs, are associated with mucosal healing in patients with IBD. And you can see the levels here. So there's that association with certain drug levels and how patients are doing. Does that sort of association carry over to ustekinumab and vedolizumab? So again, there's association data suggesting that ustekinumab levels and vedolizumab levels are associated with either clinical or endoscopic measures as well. So there is an association there. And so why do we perform TDM? And the reason is because we have a lot of inter and intra individual variability in pharmacokinetics. And I think that's important. And some of the factors that are the most important are whether there is active inflammatory disease, what the level of the inflammatory markers are, whether there's low albumin, and whether there's immunogenicity there as well, and that immunogenicity is much more important for infliximab and adalimumab than with the newer biologics, because the risk of antibodies are much lower with the newer biologics. So I'm just going to briefly talk about some patient factors that are associated with immunogenicity, and I think that helps to kind of choose which patients you're going to use on monotherapy versus combo therapy as well. So this is data looking at infliximab IV versus infliximab sub-Q. And so sub-Q infliximab is available in a lot of jurisdictions, not across the world yet, but certainly in a lot of jurisdictions. And one thing they noticed was, again, sort of the same molecule, if you gave it sub-Q versus infliximab, there's lower rates of immunogenicity and lower rates of neutralizing antibodies. So there is something about giving a medication sub-Q which lowers your risk of antibody formation compared to giving it IV. So that's one thing that's important. And again, sort of highlights one of the reasons why adalimumab has less of an antibody formation risk than an IV medication like infliximab. And then something relatively new is in terms of genetic factors is something called HLA-DQA1. And so this is found in about 40% of Europeans. And so what they found is that if you actually have this genetic polymorphism and you have either one copy or two copies of this polymorphism, that there's a higher risk of developing antibodies with infliximab or adalimumab. And so it was this very sort of nicely done study in terms of patients that were on infliximab or adalimumab, either monotherapy or combo therapy. And what they found was that in the highest rates of immunogenicity were really in patients that were on monotherapy with infliximab and carried the HLA-DQA1. And so the rate of antibody formation was 92%. So that's quite high. And then the lowest rates of antibody formation were those patients that were on adalimumab and on immunomodulator therapy and didn't carry the HLA-DQA1, and their rates of antibody formation were only about 10%. So quite a wide range of immunogenicity, and something to sort of keep in mind that there are certain patients or subsets of patients that can develop antibodies very quickly with infliximab and adalimumab. And so what are the overall rates of immunogenicity? And I kind of highlighted this before. So infliximab and adalimumab have much higher rates of immunogenicity, sort of in that 30 to 50% range after 1 year. And then the newer medications like ustekinumab, golimumab, risankizumab have much lower rates. And so that the risk of antibody formations is low. And so these patients typically don't need combination therapy with a thiopurine and can get monotherapy on their own. And so I'll focus a little bit on reactive therapeutic drug monitoring. So we know that patients lose response, and you've seen this in your clinic as well. So those patients that are on infliximab, adalimumab lose response over time. That loss of response can be up to 30% per year or 40% per year. And simple dose escalation without measuring levels actually helps, and it can result in a short-term response of about 60 to 70%. And so the question really is, if we do TDM, does it really help figure things out, or do we just dose escalate everybody and see what happens? And so this is one of our studies that we published, taking a look at patients with subtherapeutic infliximab levels. And you can see here that those patients that had subtherapeutic infliximab levels on the left, you increase their infliximab dosing, they did a lot better than if you switched them to an anti-TNF. And concurrently, if they had detectable antibodies, giving them more infliximab didn't do it very much compared to switching them to a different anti-TNF. And this is in terms of clinical remission. And so in terms of kind of putting all that together in terms of loss of response, so if you are able to get drug levels, there's 4 different possibilities. So one possibility is that you have subtherapeutic levels and undetectable antibodies, which means that you dose escalate and hopefully things will improve. If you have a therapeutic trough level and no antibodies, then giving more of the same drug will not be very helpful. And at the same sort of measure, if you have high infliximab levels, giving a patient another anti-TNF like adalimumab probably won't be helpful as well, because it's more of a pharmacodynamic failure, not because there's not enough anti-TNF on board. If you have low titer antibodies, you can try sometimes to increase the dosing of the biologic agent or add an immunomodulator. And then finally, if you have high antibodies, then those patients need to be switched, and they can be switched to a different anti-TNF and have a pretty good response to switch to a different anti-TNF. And so in the clinic, how do we do it? So, the data for this for everybody of doing this routinely, proactively for everybody is probably not that great. And so we use more of a tiered approach. And so that tiered approach is doing fecal calprotectin first, seeing if there's active disease, either endoscopically or biochemically with the fecal calprotectin. And then based on the fecal cal, if it's high, then you do your infliximab or adalimumab, TDM. And based on what your levels are, then you sort of make a dose escalation or a change in therapy. But it's sort of a more tiered approach as opposed to doing TDM for everybody. So in my clinic, what do I do? Again, the levels or concentrations are pretty similar across various assays. So for infliximab, if your levels are above 10, or for adalimumab, if your levels are above 20, then there's no real benefit of increasing your dose in most situations. But if it's lower than that, you can certainly consider increasing the dose of the medication. And if you have high titer antibodies, again, it depends on what assay you're using, but if you have high titer antibodies, then those patients should be switched to a different anti-TNF or to a different medication. And just to highlight, there's no good data for using TDM for vedolizumab, ustekinumab, or risankizumab. And just to finish off in terms of proactive TDM, so we know that in patients that have low infliximab levels at week 14, so let's say you start somebody on infliximab or adalimumab, if they have low levels at your first maintenance dose, that's sort of a poor, leads to a poor outcome. And we know those patients are the patients that end up developing antibodies. So if your levels are below 4 for infliximab, then over time, over the course of the year, there's a much higher chance of having very low levels or antibody formation. So there is that thought, well, maybe if I measure my levels early, that maybe that might actually give me a better chance of keeping patients better and in remission. And so this is data from the Therapeutic study, just taking a look at the association of week 2 and week 6 infliximab levels. And so if your week 2 levels are above 20 and your week 6 levels above 15, then those are sort of good markers that you're going to do well. Whereas if the levels are below that, in clinical practice, you might think about dose escalating those patients. Again, not a lot of evidence for that. The evidence we do have in terms of a randomized control trial is this in pediatric patients, the pilot study, which basically took patients that had Crohn's disease and randomized them to sort of 2 different arms. And the main difference between the 2 arms was that in the proactive arm, if your drug levels were below 5 for adalimumab, you dose escalated the patient. Everything else was pretty much the same. And so the real difference here is that there's a proactive arm where even if you're doing well, if you're and your CRP is normal, your fecal cal is normal, and your drug levels are low, if you proactively increase their dosing because of a low level, those patients end up doing a little bit better. So there's about a 30% difference in terms of maintaining corticosteroid-free remission by dose escalating. So that's one study. There's been a meta-analysis of multiple studies, sort of looking at whether this is an effective strategy. And again, you can sort of pick on each one of these studies, but and sort of look at why they were positive or negative. But in general, there doesn't seem to be great evidence to use proactive TDM in all patients. And so, what do I do in clinical practice is that I use it in patients that have a high inflammatory burden. So those patients that use scope and have big, deep ulcers, the ones that have a low albumin, that have high sort of inflammatory component, those are the patients that probably would benefit from TDM the most as compared to doing it on everybody. And so just sort of finishing off, so why do TDM? So there's inter and intra-individual variability in the PK and PK/PD relationship. And so again, with those patients that have a high inflammatory load, accelerated drug clearance, those are the ones that are going to have a poor outcome, and those are the ones that you might consider doing TDM. There's different validated assays across the world that you can certainly use. There is a little bit of a move towards more rapid measurements using point-of-care devices, and so there are devices that you can measure infliximab, adalimumab, fecal calprotectin, CRP within 5 minutes with a capillary blood stick. So things are changing. You don't have to wait sort of 2 weeks to get your results anymore. You can sort of get it almost immediately, which certainly would help in terms of managing patients. And so when would you use TDM? So mainly during induction in those high clearance patients, or any time during loss of response is probably the best time to use TDM, particularly for the anti-TNF agents. And then sort of just finishing off, kind of summarizing where we would use TDM. So secondary loss of response or partial response, particularly to anti-TNFs. There's no data for using it for ustekinumab or vedolizumab or risankizumab. No TDM needed for the oral small molecules either. Other places where you might consider using it, which I haven't spoken about, dose de-escalation. So your patients are doing well. They had been sort of escalated to 10 milligrams every 4 weeks initially, and now they're doing well. So you can certainly consider dose de-escalation, and using TDM is probably a good place for that to try to decrease the amount of medications you're giving. Withdrawal of immunosuppression. So we know that when you withdraw immunosuppression, your drug levels drop by on average about 2 to 3 micrograms per milliliter. So that's another area where you might consider doing drug testing. And if your levels are low, avoid stopping the immunosuppression or increasing the drug level, increasing the dose to avoid getting levels that are low. After a drug holiday, after this first dose, you can consider using TDM as well to see if there's antibodies that have developed over time. During induction and prior to maintenance therapy in high-risk patients, and then in maintenance therapy, like I said, more of a tiered approach where you do your fecal cal first, followed by TDM. So I think I'll stop there, and we'll have some time for questions. Thank you very much.
Thank you very much. We'll take questions. Since Waqqas is standing, we'll take question on his topic first, if you have any. Artie?
Thank you very much, Dr. Afif and Professor Nonthalee, for very interesting talks. I have one question for Dr. Afif and one question for Professor Nonthalee. So for Dr. Afif, I understand that in cases where you're having loss of response to biologic, sometimes adding thiopurine can help by reducing the immunogenicity. And if you decide to do that and they start to respond, how long would you continue the combination therapies for? And for Professor Nonthalee, you mentioned that the optimal time for doing endoscopy in GI bleed is 6 to 24 hours. Are there ever any situations where you would do it earlier rather than wait 6 hours?
Okay.
Thank you.
Let's take your bit first.
Sure. So it's a good question. So I think in terms of patients that have low titer antibodies and you're sort of dose escalating, you can use azathioprine or thiopurine. In addition, in terms of how long to continue it, there's not a lot of great data to suggest how long to continue it. In general, if you look at sort of patients that are on combo therapy and you stop the combination therapy, usually you would consider stopping it after about 6 to 12 months or so, and maybe it's the rate of antibody formation or immunogenicity is highest in the first year. So certainly after you've been on combo therapy, you can consider stopping it and see what happens to the trough levels. In patients that have already developed antibodies and now you're kind of catch up and add azathioprine, I think in those patients you're kind of committed to sort of more lifelong immunosuppression, or if they're doing very well, then you can at least decrease the dose to sort of a half dose to see if that's enough to kind of keep their antibody formation from forming.
Are there any more questions for Dr. Afif before we let him off? Okay, Waqqas, thank you.
Thank you.
I think, Nonthalee, you have a few questions. I think Artie's question can be taken first. And there's some online, so I'll read them out.
Yeah. So based on several studies, the clinical scenarios that we would need to go in and do endoscopy very quickly is variceal bleeding. Studies have shown that for patients with variceal bleeding, if you do endoscopy within 12 hours, the outcome might be better than just wait until 24 hours. But still, if you're talking about 6 hours, I think that, it's going to be, I think what's really important here is adequate resuscitation. It is if your patient is good enough to undergo endoscopy, I think that's really the key. If you have the facility to do it at 6 hours, and if your patient is well resuscitated, then you can do it. I don't think that's going to do any harm. But sometimes people just like to rush in to try to do endoscopy because they think that endoscopy is everything, which is not proven to be the truth based on several studies. Yeah.
Okay.
And there are some of the
Yes,
questions.
I'll read out. We are all live, so we have questions. Will I read that out first, sir?
Yes, thank you so much for a fascinating talk for both of the speakers. I have one question for Nonthalee. So you mentioned about we have many modalities for treatment of the GI bleeding, and sometimes we got a bleeding case in the area difficult to get access, and sometimes easy to get a complication, just such a perforation. The proximal small bowel is, for example, if we have a bleeding in the proximal small bowels, which modality you can go for? You have a over the scope clip, you mentioned a lot there. So you have a hemospray, or you go to just like bipolar coaptations.
Yeah. Your question is very similar to one of the questions
Yes.
that the
Will-
audience from home is
Will I
asking.
read that out so it will answer both?
Yeah, sure.
Okay. So there is a question live, which is saying that what characteristic ulcer would Dr. Nonthalee recommend to use over the scope clips as first line treatment? So that should cover both.
For Professor Ratakan's question, he's specifically asking about small bowel ulcer, which kind of equipment or modality I would use. For small bowel, I prefer clip, through the scope clip. Usually small bowel ulcers is not, is not very big, or if it is big, then, my preferred modality would be clip or conventional therapy, which is dual or combination therapy. If that fails, then hemospray would be the next step. Over the scope clip, to be honest with you, I haven't really used over the scope clip with a small bowel bleeding, because the only small bowel bleeding, which is the duodenal ulcer that I would use over the scope clip, is the bulb area, that I think that this might be GDA bleeding, anterior wall, posterior wall, kind of difficult to work with and rebleed easily. Then if I could reach the ulcer with the over the scope clip, I would do that. But posterior wall ulcer, that's the most difficult thing. Oftentimes I have to go with hemospray first to cool it off a little bit, and try to go in with second modality. So yeah, I still use conventional technique before I go to the adjunct therapy. But for the audience question about which also characteristic
Yes.
that I would prefer using over the scope clip, that would be a very big bleeding vessels in the stomach, easily to approach. Spurting. Well, spurting, if I can get it with a clip,
a
through
clip,
the
you
scope
would-
clip or a cautery, I would still go for
You would
that.
prefer that.
Right, yeah. But for very big ulcers that I know that the non-bleeding visible vessel is larger than 2 or 3 millimeters, I know that I'm going to unroove it. If I use cautery, I know that it's going to become spurting. If I use cautery, something like that, I would go for over the scope clip. Yeah.
Fine. So we have quite a few questions. If you don't mind, I'll read them out. So one of the colleagues on live is asking that would you consider H. pylori testing during index upper GI and bleeding? And if you do, which test would you use? And if you don't do the testing at index endoscopy, when would you perform the H. pylori?
Okay. I would do HP testing during the index endoscopy, unless is blood everywhere and the patient is unstable and I'm trying to deal with the bleeding, then I won't, spend the time doing biopsies. But if I can secure everything, the bleeding stops, and I would still do the biopsy at the end of the procedure.
Okay.
I would do biopsy. I would not do the rapid test, because that can create false positive. If I don't do the biopsy during the index procedure, I will wait until I do a follow-up EGD for patients with potential high-risk ulcer, that I will make sure that I will make that the ulcer heals. Yeah.
Okay, there is another question which you probably have answered. In what they're asking is, if patient with refractory bleeding, what would you choose, OTS, TE, or hemospray? If all options are available. So if you have all the options, which one, I suppose?
For recurrent bleeding?
Yeah, refractory bleeding.
Refractory bleeding. So obviously I would do a second attempt.
Okay.
Refractory bleeding could mean that within that index procedure and I fail using conventional technique. I want to try something that's more effective, then I would go for over the scope clip. But if I don't have that in my toolbox, then I would go with hemospray. Sometimes I use APC just to slow down the bleeding a little bit, and then I'll go for another modality.
Yeah.
But if it is a recurrent bleeding, meaning not in that index endoscopy, then I might just use the standard technique again if the lesion is easily approached. But if it's a difficult lesion, I would go with the over the scope clip.
Okay.
The
Great.
data also support that.
Yeah, good. Anyway, can I ask a question then? Obviously, a lot of these data that suggest various modalities to be used these studies are done by experts like yourselves, but in real life, people like me who are old don't go and do endoscopy straight away. So we rely on younger fellows and things like that. Does that affect the effectiveness? I mean, spray, you don't need to be
I was gonna say that you can go with spray.
Yes.
You can be like 75 years old and you
Yes.
can still
use
click
the spray.
that button and the spray will just spray.
Yes.
Yeah, so I like I said, if cost is not an issue, I think that everyone should learn how to do spray
Yes.
because it technically is easy, but the device assemble and the checklist
Checklist.
can be troublesome because you have to make sure that the catheter is dry. It can be drops of
Yes.
water.
Yeah.
Otherwise, the spray won't go. Technically, it's not that difficult because you just push that button and it will work. But preparation,
Yes.
device preparation is key. So you got to understand how the thing
Yes,
works.
I think you have to be familiar. The reason I have interest in spray, this all originated for Afif and Dr. Waqqas information, is that, this spray was invented in Afghanistan when the US force were fighting. So they used it to stop bleeding on the battlefield, and they've modified it to that. So it's a very effective
Right.
modality. But you're right. I mean, to use something, you have to be familiar with it.
Right.
Can-
One thing I should mention, which what and the audience did ask about it, is embolization. When do I choose embolization versus endoscopic therapy for refractory bleeding? Like you were just saying,
Yes.
if you're not familiar with over the scope clip or overstitch or even monopolar, but if you have a interventional radiologist,
Around. Yes.
embolization is always effective.
Very effective.
It's always effective. There was one study that was published 5 or 6 years ago looking at high risk peptic ulcer bleeding after endoscopic therapy, and they divided the patient into prophylactic,
yes.
prophylactic embolization versus no prophylactic embolization. Well, the prophylactic embolization for high risk bleeding is not effective. The outcomes are not different. But if you have refractory bleeding, embolization is still your good friend. That always works if you can't manage endoscopically.
You have a question, sir?
You just answered me the questions. We talked about the J bleeding last year about the PCAP in the post-endoscopy treatment. But for the pre-endoscopy, you have any information, any evidence base to use the PCAP in the pre-endoscopy before we going to the therapeutic interventions?
We haven't tested PCAP before endoscopy in high-risk patients only because we kept them NPO, like absolute NPO, so we wouldn't be able to feed them the medications.
Yes.
But I would think that if post-procedure, if PCAP works for post-procedure, for pre-endoscopic procedure in patients with, low risk, you can perhaps use it too. Yeah.
I mean, I think one way forward would be that a study would be that you give them IV bolus pre-endoscopy because you want them to be nil by mouth and then go on PCAP post
Yeah, that's what we did in our
Yeah.
study, and it
that-
seems to
that
be
would seem to be-
non-inferior.
yeah.
Yeah.
Okay, I think if there's no more questions, it just remains for me to thank excellent speakers in this session, and we are really indebted to both of them and to the crowd to staying firm at this late hour at the end of the meeting. So thank you very much. It's been a pleasure.